I represent the Medical College Medicine Department team for the undiagnosed and with master class. And thank you, Dr. Ramyan, for coordinating. So this is the last master class from Medical Department. Over to you, ma'am, to continue with this.
Thank you, Dr. Anita. So today will be the last masterclass from CMC Vellore. And presenter is Dr. John Roy. He's a final year medical student, and he'll be presenting a interesting case with cardiovascular system findings. Over to Dr. John Roy.
Good afternoon. I'm presenting about Mr. A, a 29-year-old gentleman who's come from Assam. He works as a madrasa teacher, and his presenting complaint is dyspnea on exertion for 20 years, which has worsened over the last 3 months, palpitations on exertion for the last 10 years, pre-syncope and angina for 3 months. Going into the history of presenting illness, he was well until the age of 10 years of when he was 10 years old, when he first noticed that he was unable to keep up with his peers in the physical activities that were done at school. So when he noticed that initially when he used to run for a distance of within less than 5 minutes, he would feel the need to stop because of significant breathlessness and fatigue. And this was much lesser in comparison with his other peers. Subsequently, over the next 5 years, he mentions that his symptoms have worsened to the point that he would develop breathlessness even on walking on plain ground level for less than 100 meters. He also noticed that he had palpitations on exertion, which I shall come to later. So he has modified his physical activity in a way that he would compensate for the breathlessness that he's having. He also describes two episodes in the past 3 months where he was woken up from sleep after 2 to 3 hours of going to sleep with a sensation of intense breathlessness and suffocation. It was also associated with significant diaphoresis, sweating and cough, and he had to sit up and put his legs down to get relief from that episode. He gives no history of breathlessness on a lying down in a flat position. The breathlessness is not associated with cough, expectoration, or wheeze. Regarding his palpitations, it's been going on for the last 10 years. It occurs on a daily basis with exertion. It's associated only with exertion, and it reduces with rest. He describes it as being fast and regular, and there is no increased urination post the palpitation episode, and the palpitation is not associated with syncope or chest pain. In the last 3 months, when he was standing in class and teaching, he describes that he developed sudden onset lightheadedness to the extent that he had to stop the class and sit down. And when he sat down, his symptoms had significantly improved almost immediately. No loss of consciousness, involuntary urination or defecation, or jerky movements of the limbs or tongue bite were associated with these episodes. He also describes a dull, non-radiating central chest pain, which is also exertional and relieves on rest. He says that it occurs when he walks fast for a duration of 100 meters. No history of pedal edema, blood in sputum, bluish discoloration of the skin or mucous membranes, or reduced urine output. He denies any fever, joint pain, skin rashes, or involuntary movement of the limbs now or in the past in childhood. No history of recurrent respiratory tract infection in childhood, and no history of fever. He does not have any other comorbidities, and there is no history of drug abuse, previous surgeries, or dental procedures. He is born to non-consanguineous parents. He is one of 6 siblings. He is the last in the family, and there is no history of cardiac diseases in the family or sudden cardiac death in the family. So summarizing, I would like to present this 29-year-old gentleman who has come with progressive breathlessness, fatigue, and palpitations for the past 20 years, now with a worsening over the last 3 months in the form of worsening shortness of breath, chest pain, and 2 episodes of pre-syncope.
So, Dr. John, based on your history, this symptomatology has been going on for 20 years, right?
Yes.
Do you think it's a congenital disease or an acquired disease?
Well, considering that it started at the age of 10, I would like to keep a congenital process higher than a acquired process.
So based on this history, what are the congenital disorders you're considering?
Any congenital heart lesions, congenital stenotic lesions, like a bicuspid aortic valve or a congenital mitral stenosis. Any stenotic lesion is what I would think of, stenotic or even regurgitant lesion.
What is the normal age group for presentation of a bicuspid aortic valve?
They would be symptomatic by the third or fourth decade of life.
Usually in the 50 to 70 years. So here is a person who's presented at 9 years of age. So any other congenital causes you're thinking of? Any other congenital cause of stenotic disease, do you know?
Ma'am, hypertrophic cardiomyopathy where there's a dynamic left outflow obstruction could be possible. Uh, a congenital pulmonary stenosis could be possible, or a primary pulmonary hypertension could be possible.
Congenital PS is possible. Then what about congenital AS? Any other congenital syndromes you know which can present at 9 years of age in aortic stenosis?
Ma'am, there are congenital forms of aortic stenosis where there is a subvalvular membrane, or there are certain structural hourglass deformity, or a
There is subvalvular and
supravalvular stenosis can be seen in Williams syndrome.
Okay. And anything else? You said there is a bicuspid aortic valve. No. Any other form of that valve can present early?
If there is an associated aortic.
Okay, if there's an unicuspid aortic valve, then they can present earlier. Bicuspid aortic valve usually presents later.
Yes.
Okay, so congenital aortic stenosis is definitely a possibility in this patient. Then any other congenital disorders which can present in the first decade of life? Acyanotic, where they can have shortness of breath, presyncope.
An acyanotic heart disease like a ventricular septal defect, or an atrial septal defect
also can present with palpitations and breathlessness. So those are the congenital disorders you have to consider in this patient.
Yes.
Go back to your history. So based on your history, which chamber of the heart is involved?
Ma'am, considering that his symptoms are dyspnea and palpitation, I would like to keep the left side of the heart to be involved.
So based on dyspnea, we think the left side of the heart is involved. Is the left atrium or left ventricle?
Left atrium is what is the likely symptom based on predominant dyspnea.
Okay, dyspnea can be left ventricle, but then here, what about angina and syncope? Based on that, which chamber do you think is
ventricle involved? Would be involved?
So left ventricle is also involved,
yes,
right? Angina is there, means left ventricle is also involved. So based on your history, we have localized it to the left side of the heart and also the
ventricle.
And maybe the atrium, according to you, because there is
breathlessness.
So we are expecting a left-sided heart lesion, which is involving either the atrium and the ventricle, which is between the atrium and ventricle, or between the ventricle and the big blood vessels, the major arteries. Okay, next. Why did you look for post-palpitation diuresis? Where does it localize to?
Ma'am, post-palpitation diuresis occurs when there is an arrhythmia that is involving above the level of the ventricle, supraventricular arrhythmia, leading to atrial natriuretic peptide release and subsequently diuresis and natriuresis.
Good. So whenever there is an atrial fibrillation or atrial arrhythmia, the ANP gets stimulated, and once they have palpitations, they'll have diuresis. So that's a very good point. Okay. Next. Okay, next. Why did you ask for hemoptysis in this patient when you have localized to the heart?
Ma'am, if there is a subsequent, because if the heart is causing a subsequent pulmonary pulmonary hypertension, I would expect hemoptysis to occur. Pulmonary venous hypertension, pulmonary arterial.
You asked for bluish discoloration in this patient, no? What did you expect that person to develop that you asked for bluish discoloration? You're thinking of cyanosis, right?
Yes, ma'am.
Somebody with a congenital heart problem. So what are you thinking?
If there is a change in the shunt right to left the shunt has changed the direction, there's Eisenmengerization, he might develop a bluish discoloration of the skin or mucous.
So you were still considering a congenital heart disease when this was happening?
Yes.
Okay. And what about this joint pain and all? What were you looking for?
I was looking for any past history to suggest a migratory rheumatic fever, ma'am, acute rheumatic fever.
And recurrent respiratory tract infection, what were you looking for?
Ma'am, acyanotic congenital heart diseases with increased pulmonary blood flow would predispose them to recurrent respiratory tract infections.
If you have a cyanotic congenital heart disease, what are you predisposed for? There is pulmonary oligemia, right? So what
Yes, ma'am.
infections can occur?
Uh,
Something which needs a lot of air and less blood.
of tuberculosis.
Yeah,
ma'am.
tuberculosis. So recurrent respiratory tract infections do not occur in cyanotic heart diseases.
No.
Okay, go on. Why did you ask for thyroid disorder, sorry, and bronchial asthma?
Uh, One is they could worsen the existing heart disease that he has, thyrotoxicosis, bronchial asthma, because we would be using beta agonists that could also worsen his underlying heart. If it's already a strained heart, it would be compensated further.
Any drugs can cause, not drugs of abuse, but they are used for weight loss. What are the drugs which can cause cardiac valvular diseases?
Amphetamines,
What diseases, what valve diseases do they cause?
mitral valve disease, mitral stenosis.
And pulmonary also. Any endocrine disorders associated with valvular heart disease?
Ma'am, hyperparathyroidism and carcinoid could.
Carcinoidism. Okay. Okay, we'll move on. So sudden cardiac death, what were you looking for, Dr. John?
Ma'am, if this was a hypertrophic cardiomyopathy, that would predispose him to a sudden ventricular arrhythmia and a sudden cardiac
Okay,
death.
so you're still thinking of a aortic stenosis, a subvalvular
Yes, ma'am.
aortic stenosis. Okay. Go on, continue.
On examination, he was conscious, cooperative, oriented to time, place, and person. His anthropometric measurements showed that he had a height of 166 centimeters with a BMI of 21. His upper segment to lower segment ratio was less than 1. It was 0.93. And his arm span was 164. It was not more than his height.
What is the importance of looking at upper segment, lower segment ratio and arm span? In normal people, what is it and what happens in other disorders?
In a normal person, the upper segment, lower segment should be less than 1, ma'am. But if it is more than 1, that would indicate a delayed epiphyseal closure, which could be seen in Marfan syndrome. And if the arm span is more than 5 centimeters of the height, that is also a feature of Marfan syndrome.
Correct.
Uh,
So what are the diseases which are associated with Marfan syndrome? What are the valvular diseases?
Ma'am, Marfan syndrome would be associated with aortic regurgitation, aortic root dilatation.
So the aortic regurgitation is due to aortic root dilatation in Marfan's. Okay. Any other general examination findings you can look for in Marfan's?
Ma'am, the thumb and the wrist sign.
Something to do with the eye?
Ma'am, they would have a supralateral lens dislocation, which would be manifest with iridodonosis.
And they are also often myopic.
Yes, ma'am.
Go on.
He did not have any pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Afebrile, he was breathing at 16 per minute.
Because you've mentioned all this, what is the importance of looking at each of the general signs in cardiovascular system? Why did you look for pallor?
Pallor, ma'am, particularly because pallor itself, anemia would predispose them to developing heart failure. There would be flow murmurs that could be there in a severely anemic person.
Somebody has an MDM, can it be a flow murmur?
Ma'am, the MDM is very unlikely to be a flow murmur.
Because all flow murmurs are
They're all systolic.
systolic murmurs. So when you have multiple systolic murmurs, you should look for an anemia too, because flow murmurs are systolic murmurs. Icterus, when can you have icterus in somebody with cardiovascular disease?
Ma'am, icterus could be present if there's a congestive hepatopathy, right heart failure.
Remember, congestive hepatopathy increases only the enzymes. Here the bilirubin is gone up. So what happens?
A hemolysis can
Hemolysis secondary to
a prosthetic valve or a
valve. Then
If there is a sudden hypotension, he's in failure and he develops a shock liver.
We think only of hemolysis. So remember, because bilirubin goes up for you to develop icterus, not your enzymes. And cyanosis to look for?
Cyanosis to look for features of if it was a congenital heart disease, or right to left shunt, or a
Okay, we're thinking of a congenital cyanotic heart disease or Eisenmenger's. Clubbing, when do you develop clubbing in cardiovascular disease?
if there is infective endocarditis, if there is prolonged hypoxia.
Only infective endocarditis. Do we get lymphadenopathy in cardiovascular disease?
Sarcoidosis could have cardiac sarcoid.
Sarcoidosis will cause then which cardiac disease?
Uh,
What type of cardiomyopathy?
restrictive cardiomyopathy.
Cause both restrictive and dilated.
Uh,
Pedal edema to look for?
Pedal edema is a sign of right heart failure or biventricular failure. He was breathing at 16 per minute, abdominothoracic type of respiration with no use of accessory muscles. His saturation was 98% on room air. On examination on his blood pressure, his right upper limb had a blood pressure of 90/66 millimeters of mercury. His left upper limb was 90/64 millimeters of mercury. And his right lower limb and left lower limb, right lower limb was 100 and left lower limb was a 104 systolic pressure at millimeters of mercury. The pulse.
Based on this blood pressure, now you're considering what valve lesions?
Based on this, ma'am, I would keep my differential of a left-sided stenotic lesion higher up because of the low pulse pressure.
Low pulse pressure and systolic blood pressure is also low.
Yes,
What is the normal or expected blood pressure on somebody who's got an aortic regurgitation? Somebody only has an AR, just an AR, even if it's a mild or moderate AR, what will be his systolic blood pressure?
Very high, ma'am, 180, 200.
It will be about 200. So remember, in AR, whether it's even mild or moderate, your blood pressure will be very high. So when you have a low blood pressure like this, you're expecting a stenotic lesion.
Yes,
Okay.
His pulse rate was 64 per minute, regular in rhythm. It was a low volume type of pulse, which was slow rising and late peaking. And
What do you call that?
Pulses parvus et tardus.
Which is the parvus and which is the tardus?
Ma'am, the low volume is the parvus and the tardus is late peaking.
Parvus means slow. So slow rising is parvus and tardus is late peaking.
Yes.
Okay.
All his peripheral pulses were present, ma'am, and equally felt. No radial or radiofemoral delay. His jugular venous pulsations were not visible. There is no peripheral signs of infective endocarditis. He did not have any dysmorphic features or any stigmata to suggest a congenital heart disease.
What dysmorphic features you look for?
Ma'am, if I look for features, if I was anticipating Down syndrome, mongoloid facies, epicanthal fold.
What do you look for in the heart?
Simian's crease and
yeah, single palmar crease.
Is a Simian's crease.
Epicanthal fold.
Yes, ma'am.
And then
he would have a
what
wide
are the
gap.
congenital syndromes associated with heart disease? If somebody has a webbed neck.
A Turner's syndrome.
And they also can have
coarctation of
aorta and an AS. So you have to look for Turner syndrome. That is a male, sorry.
Yes, ma'am.
Okay. Anything else? What is the most commonly associated abnormality with congenital heart disease? Something to do with the hands and feet.
Yeah, ma'am. Polydactyly or a.
Yeah. So then you have a polydactyly.
Yes.
There's a syndrome called Vater where you can have congenital heart issues.
Yes.
Then there is Noonan's
Yes.
for men. All those are associated. So you have to look for all of those to look for congenital heart disease.
Ma'am, on inspection, his chest was bilaterally symmetrical. The trachea appeared to be midline. He did not have any spine deformities like kyphosis or scoliosis. There were no visible scars, dilated veins, or there was no precordial prominence. Apical pulsation was noted in the left sixth intercostal space at the mid-axillary line on inspection. There was no pulsations that were visible in the epigastric, suprasternal, or aortic region.
When do you get this? When you're looking for pulsations in the epigastric, suprasternal, aortic region, what are you looking for? They indicate what to you?
It's a hyperdynamic circulation.
So it's a hyperdynamic circulation. So it is what valve lesion?
Aortic valve, regurgitant valve
So you're
lesion.
looking for a regurgitant valve lesion. Why did you have to specifically mention it based on the previous line? The apex is shifted,
It was shifted down and out, ma'am.
indicating what type of hypertrophy?
Consent, a dilated or a cardiomegaly, eccentric hypertrophy.
Hypertrophy, which is indicative of what?
A regurgitant lesion occurring, ma'am.
Okay, if it is a stenotic lesion, then what kind of hypertrophy occurs in the heart and where do you expect the apex to be?
If it was a stenotic lesion, it would be a concentric hypertrophy. A concentric hypertrophy would not be shifted outward or downward.
It will be shifted laterally.
Laterally, ma'am.
Why do you have to look for kyphoscoliosis in somebody with cardiac problems? What are the
Before commenting on the apex, I need to know whether there's kyphosis or scoliosis, which could shift it.
one good answer that is? So you're looking at the kyphoscoliosis because you want to know where the apex is. Any congenital neurological problems you can think of associated with kyphosis and scoliosis and cardiac issues?
One of the causes for aortic stenosis was ochronosis, which could
Not
have
such difficult diseases. Some named ataxis. Somebody with pace caves.
Friedrich's attack
so
could have a dilated cardiomyopathy.
cardiomyopathy. So you should look for congenital neurological issues also when you're
Yes.
looking at cardiac issues.
Yes, ma'am.
Okay.
Ma'am, on palpation, the trachea was confirmed to be in the midline. The apex beat was felt in the left sixth intercostal space in the mid-axillary line, and it was heaving in character. There was a palpable second heart sound felt in the left second intercostal space, and I could feel a systolic thrill in the right second intercostal space. There were no epigastric pulsations or palpable heart sounds, and there was no palpable carotid thrill.
When the apex is shifted down and out, no, what kind of character are you expecting in
Ma'am, I
apex?
would have expected a hyperdynamic apex, but in him it was quite sustained and heaving. It was lifting the finger.
Was it in one space or two spaces?
The apex was in one space, ma'am.
Yeah, sure.
And it was
Okay, we'll go on. We'll see whether we have any other lesion which is explaining this. So there was a palpable second heart sound. What do you want to convey with that?
that there is a pulmonary hypertension that is present, ma'am, or there's a pulmonary dilatation, pulmonary artery dilatation.
What do you think about sentences 4 and 7? Yeah, do you think they go together? There's a systolic thrill felt in the second intercostal space. What does that tell you about the severity of the disease?
A systolic, a palpable thrill will indicate that it's a very loud murmur.
Loud murmur indicating that
it's a very severe stenosis.
okay, it is probably a severe stenosis. In that case, wouldn't they have a carotid thrill?
Maybe because if the lesion was hypothesizing that if the lesion was less subvalvular, it may not radiate to the carotid.
What is the flaw in that argument? That it is a subvalvular lesion, then where will you hear the murmur and the thrill? I agree with you, subvalvular may not conduct up to the carotids, but if it is a subvalvular lesion, it is below the valve, right? So in that case, where will the murmur and the thrill be present?
Third intercostal.
It will be in the second aortic area, right? So you are hearing it in the, the
Yes, ma'am.
herbs area, sorry. That is the third intercostal space on the left side is where you will hear the thrill, murmur and feel the thrill. But this is in the first aortic area, which means this is a valvular lesion.
Yes, ma'am.
In that case, a carotid thrill has to be there.
The left heart border corresponded to the apex and the right heart border was at the right sternal border on percussion. The left second intercostal space was dull on percussion.
What do you want to convey with each of these? So the left heart border corresponds to the apex. What do you want to convey with that?
That there was no So there was no pericardial effusion or an LV aneurysm that could cause apex to be, I mean, the percussion dullness to extend beyond the apex.
And right heart border?
Right heart border, if there was a mediastinal pathology or a lung, a pulmonary pathology, or a pericardial effusion again, could.
Or even a right atrium and right ventricular enlargement.
Yes.
Okay. Basically the RA enlargement. RA enlargement.
Yes.
And second intercostal space was dull on percussion.
Again, indicating a dilated pulmonary vasculature.
You want to say this pulmonary hypertension.
Hypertension, yes, ma'am.
Was there any parasternal heave?
No, ma'am, I could not appreciate a parasternal heave.
What are the grades of parasternal heave?
Ma'am, grade 1 is when it is visible but not palpable. Grade 2 is when it is visible and palpable but obliterable. And grade 3 is when it is visible and palpable and not obliterable.
And there is no parasternal heave in this
No,
person.
ma'am. Yeah.
What does parasternal heave tell you?
It tells me that there's a right ventricular hypertrophy or there is a left atrial enlargement.
No, it's a right ventricular hypertrophy, indicating what? Pulmonary?
Hypertension, a severe pulmonary hypertension.
What history in this patient tells you that he has pulmonary hypertension?
Ma'am, the pre-syncopal episodes could.
Syncope is associated with which valvulation?
Aortic stenotic.
Why do people in aortic stenosis develop syncope?
Ma'am, the reason for syncope in aortic stenosis is there is a fixed stenotic lesion, and when they exert themselves, there's peripheral vasodilatation, and as a result of that, the cerebral blood flow, I mean, it's not able to match the
So
requirement.
it's a sudden fall in the peripheral perfusion because the stenosis is fixed.
Yes, ma'am.
When when there's vasodilatation, the heart is, like you said, is not able to match and increase the cardiac output, and because of that, they have a syncope. So what were we talking about? Sorry, I'm not.
Ma'am, pulmonary hypertension and why?
Pulmonary hypertension.
What is the symptom in his history?
Yeah, so this is not, so syncope is not due to pulmonary hypertension. So
Yes.
what symptom it tells you that he has got pulmonary hypertension?
The worsening dyspnea on exertion.
Dyspnea. So when somebody with cardiac valvular problem develops dyspnea, they have developed pulmonary
Yes.
hypertension. Why do people with aortic stenosis have angina? What are the reasons for angina in these people?
Ma'am, one reason is because of the concentric hypertrophy. There's not enough vessels to meet the mismatch, demand supply mismatch. The second reason could be that there is increased LV end diastolic pressure because of the hypertrophy, and that impairs coronary perfusion. And the third reason could be that if it is a aortic stenosis that extends into the coronary ostium, the calcification, that could also cause a.
What is the cause of mismatch?
Ma'am, there's muscle hypertrophy.
One is muscle hypertrophy and second is what? Reduced?
Uh, coronary
Reduced capillary concentration, like the number of capillaries are less compared to the muscle.
Yes.
So there's two reasons for oxygen demand mismatch in patients with aortic stenosis, and because of that they can develop angina. So from this we realize angina and syncope are clear symptoms of aortic stenosis. And again, dyspnea is also a symptom of aortic stenosis when it develops later. So this is chronological order of symptom development is very important. Do you understand? So that is what the mnemonic, it's called ASD. Angina, syncope and dyspnea.
Yes.
And angina is the initial symptom to develop.
Ma'am, on examination, in the auscultation of the aortic area, the first and second heart sounds were heard. The second heart sound was loud. There was a harsh ejection systolic murmur of grade 5/6. It was a long duration murmur with late peaking, well late into the systole, and there was a crescendo decrescendo configuration of the murmur with radiation to the carotids, both the carotids. It was best heard with the diaphragm of the stethoscope at the right second intercostal space and sitting and leaning forward position. I had also done maneuvers, so on standing and inspiration and hand grip, his murmur felt to be decreased.
Okay, so that's a good point. So in AS, what happens to the aortic sound?
Ma'am, if it is a aortic stenosis due to a rheumatic heart disease where there's a calcification, I would expect the aortic sound to be softer. But
Okay. Always in AS, the aortic sound will be soft, whether it's rheumatic or congenital, because both have calcification. Okay, so when you're saying the second sound is loud, what do you want to convey to us?
there is a pulmonary
It's a
component.
pulmonary sound. Okay. Difficult to hear usually, yeah, by the
Yes,
way.
ma'am.
Mm.
The
Based on this auscultation, do you think it's a severe AS?
yes,
What
ma'am.
tells you? Because
Because of the late peaking murmur, ma'am.
late peaking. So when you know it is a severe murmur when it is late peaking, because the stenosis is so severe, the moment the blood flow across is so reduced that it peaks late. Actually, I would put, and the third thing you're talking about maneuvers, no, I will say it increases on what? Squatting and expiration.
Yes,
I would
ma'am.
put it like that rather than saying it decreases on standing and inspiration.
Yes, ma'am.
What murmur are you worried about that you have done all these maneuvers?
HOCM.
HOCM, maybe. In
Uh,
that case, it is better to do a Valsalva or do
A Valsalva would differentiate.
what other valve lesion can cause an ejection systolic murmur and can confuse you?
Pulmonary stenosis, ma'am.
No. Something murmur in the apex which radiates to the base of the heart. A mitral valve prolapse
Yes.
with anterior radiating murmur, you can have this
Could have.
problem. Yeah,
Yes,
could
ma'am.
be. So in that case, you have to differentiate both the murmurs. That is
Yes.
why you have to do the maneuvers.
Yes, ma'am.
What is Gallagher phenomenon?
Ma'am, Gallagher phenomenon is when there's a selective, preferential filtering of the high-pitched sound that radiates to the apex, ma'am, seen in aortic stenosis.
The high pitch sound alone is
Going to the apex.
Okay. So how will you differentiate Gallagher's phenomenon from a MR murmur?
Here, because of if the murmur, if it radiates to the axilla or the back, would tell me that it's a primary mitral valve disease.
Okay.
Ma'am, in the apex, the S1 was soft. There was a high-pitched, soft-blowing pansystolic murmur of grade 4/6, which radiated to the axilla and to the back, and best heard with the diaphragm of the stethoscope in the left lateral position with breath held in expiration. There was no S3 or S4 related, ma'am.
Why did you look for S3?
Ma'am, an S3 would indicate severity of the mitral regurgitation. In the pulmonary area, the first and second heart sounds were heard and the S2 was loud. The ejection systolic murmur from the aortic area was heard conducted with lesser intensity. And similarly, in tricuspid area, the first heart sound was soft and the ejection systolic murmur from the aortic area was heard conducted with lesser intensity. Ma'am, rest of the systemic examination, normal vesicular breath sounds were heard with no added sounds. His abdomen was soft, non-tender with no hepatosplenomegaly and there was no free fluid. He did not have any focal deficits and both his plantars were flexor. My final clinical diagnosis would be a multivalvular heart disease.
So what valves do you think are involved?
Ma'am, aortic and mitral valve are the culprit valves. Yeah, ma'am.
They're both affected. Okay.
In the form of severe aortic stenosis and moderate mitral regurgitation.
Why do you think it's moderate? What in the physical examination could tell you that
Cardiomegaly, it's severe.
he's got eccentric
It would be severe mitral
it
regurgitation,
could
ma'am.
be severe mitral regurgitation. Okay.
And yes, ma'am, it's a severe mitral regurgitation. The etiology, I would like to consider a congenital etiology, a bicuspid, though the age of presentation is a little lesser than expected. A bicuspid aortic valve disease with a secondary mitral involvement, with evidence of pulmonary artery hypertension and not in it.
In case there is a degenerative aortic valve disease, what mitral valve disease do you expect? Why do you think, in what way aortic valve disease can cause other valve diseases?
Ma'am, if the aortic valve disease results in a left ventricular enlargement or hypertrophy, that could cause a dilatation of the annulus or a.
So in that case, what will be the severity of the MR?
It would not be very severe, ma'am.
It will not be a severe MR. So because it's only an annular dilatation, even in those cases, even the murmurs may not be significant because we see so many dilated cardiomyopathies. No?
Yes, ma'am.
How many patients we are able to hear the murmur?
Yes, ma'am.
Because the
Okay.
flow is a very low flow across the valve.
Yes, ma'am.
So,
A mitral valve prolapse, maybe, ma'am, or
mitral valve prolapse. In that case, what will happen to the S1?
it will not be soft.
It will be loud.
And an
So
ejection
the
click.
MR with MVP will have a loud S1. So that is the only condition in MR where you have a loud S1. It's because of the added click.
Yes, ma'am.
So there will be a loud S1. So how was the S1 in your patient?
It was soft, ma'am.
Soft. What kind of aortic valve disease can cause mitral valve disease?
I
If you have AR and you have, what murmurs can you develop?
in an additional murmurs in an aortic.
Aortic regurgitation.
There would be a mid-diastolic murmur heard.
Due to what?
Heard in the apex because of the regurgitant stream that is making the mitral leaflet
Vibrate.
Yes.
So it actually hits the mitral leaflets and makes it vibrate. So that is AR. Then anywhere else you can hear Austin murmur when you can have flow MDMs. When the flow across the mitral valve is increased. Where the flow is more, but the valve is normal. Anywhere else?
VSD or
VSD and ASD. So all of them will have flow mitral murmurs.
yes, ma'am.
So an aortic regurgitation can have cause a mitral valve disease, but it is not. Aortic stenosis usually does not cause mitral regurgitation. Anything else? Any other any other causes you're considering in this person
Uh,
for this valve disease?
some-
What will you hear in a bicuspid aortic valve disease? Again, it can cause a loud S1.
Yes, ma'am.
Is it?
The name of
No, you can hear an ejection click. So again, in somebody with bicuspid congenital aortic valve disease, if it's not calcified, you can hear an ejection click, especially if they present early. And the ejection click, the clue is there'll be a loud S1.
yes, ma'am.
Okay, so again, our patient did not have a loud S1, right? So it's unlikely that he's got a bicuspid aortic valve. Would you like to consider any other cause for this multivalvular heart disease?
Rheumatic is very, very less likely, but yes, the combination rheumatic heart disease causing an aortic stenosis is less but plausible.
No. Rheumatic heart disease causing aortic stenosis is nearly impossible, like you're saying, but there is mitral involvement also, no?
The primary mitral valve due to rheumatic heart disease, and he also has an
Bicuspid aortic
Yes.
disease. Want to invoke two pathologies now. Don't want to give the Ockham razor. Why don't you think both are due to aortic RHD, man?
yes, ma'am.
See, he's too young to develop a bicuspid aortic valve problem. I'm telling you, unless you're saying it's a unicuspid aortic valve. What are the forms of aortic valve stenosis can occur? So it can be bicuspid,
Unicuspid,
then.
some membranes in the sub.
Okay, they can occur membranes then.
Uh,
Rarely, it can be quadricuspid also. So the aorta can have so many malformations. So all of them will develop aortic stenosis because of the flow shear.
yes, ma'am.
Out of which when the cusp is single only, then the stenosis will be severe and they'll develop early. Another supravalvular aortic stenosis. In that, what syndrome did you say it was?
Williams syndrome.
What will you look for in general examination?
They would have a typical features on the face such as wide set eyes, a protruded nose.
They'll have elfin faces.
Elfin faces.
Okay. Can this be HOCM still? So we looked at supravalvular. Where will the murmur be in supravalvular aortic stenosis?
It would be localized to the second.
It will be localized to second, and it can be higher also. It can be over the clavicle and it will radiate, and sometimes it can radiate to either side of the
Yes, ma'am.
based on whether they have associated coarctation or not.
Yes, ma'am.
Okay, so that is one thing. In we discussed in HOCM, it is in the second aortic area.
Yes, ma'am.
So can this still be a HOCM? What happens to the cardiac apex in HOCM?
I would not get a thrill if it was an HOCM.
I agree. You will not get a thrill in the aortic area. But can you explain the apex by saying this is HOCM?
This is shifted down and out. If
Can be
not
shifted
possible,
down and out, but what happens to the apex in HOCM?
it should just be shifted laterally or not shifted. It won't be shifted.
No, there is one specific thing.
Oh, ma'am, that would be a double tapping apex.
Double tapping apex.
Yes, ma'am.
So that also he doesn't have,
It
so we
will-
can't say this is a
HOCM.
HOCM. So now we are again stuck. I would argue this is a rheumatic heart disease, huh?
Yes, ma'am.
That is the easiest thing to say because he didn't have MS, but he's got an MR. There is mitral valve involvement.
Yes, ma'am.
And then he's got a bicuspid aortic valve.
Yes, ma'am.
What are the levels at which mitral valve can get involved? We discussed that it can have an annulus problem. Then how else can mitral valve get involved?
That could be a papillary muscle dysfunction.
Papillary muscle dysfunction. Then
The chordae could get ruptured, the
Okay.
chordae tendineae involvement, or the ventricular muscle. I mean, the muscle itself.
yeah, so they can have all that. So the muscle, the papillae, the chordae,
Okay.
and the valve at the level of the valve. So at these 4 levels, you can get mitral regurgitation.
Yes, ma'am.
So which disease involves all this? There is cusp involvement, commissural involvement
Infective endocarditis. ma'am.
in rheumatic heart disease.
Yes.
Okay. RHD. Do you think this MR is acute?
No, ma'am, there was cardiomegaly, so that means there is time for it to develop.
Okay. So one is there's cardiomegaly. Second is usually acute MR. How will they be? They'll be
Sudden onset breathlessness, they'll be
cardiac
acutely sick.
shock, and the murmur will not have time to develop. So it will be a shorter. It will not be a full PS.
Yes, ma'am.
So we are now reasonably certain this is a chronic AS and a chronic MR.
Yes, ma'am.
Uh,
It's an unlikely combination.
unlikely combination. Okay. With evidence of pulmonary hypertension.
Yes, ma'am. Not in atrial fibrillation, without any evidence of heart failure currently, without signs of infective endocarditis or active rheumatic carditis.
What are the signs of active rheumatic carditis?
Ma'am, they would have erythema marginatum, arthritis, skin nodules.
What is a
Fever.
No. Acute rheumatic carditis. We are not going to rheumatic fever. What will you look for in somebody with acute rheumatic carditis? It is what carditis?
It's a pancarditis. ma'am.
Carditis.
It's a pericardial involvement. They would have pericardial rub or a pericardial effusion.
Which part of the auscultation cycle you hear the pericardial rub? It's a diastolic or a systolic sound?
Diastolic sound.
It's a diastolic sound. Okay, so you can hear a pericardial rub. Then
if it is a myocarditis, they would have a tachycardia that is out of proportion to what.
Tachycardia and features of cardiac failure.
Yes.
Then endocarditis, what murmur will they have?
Regurgitant murmurs.
What is it called?
Mitral, Carey-Coombs murmur.
Carey-Coombs murmur. Do you think this is Carey-Coombs murmur?
Carey-Coombs murmur is a mid-diastolic murmur.
Correct. Yes. Try tricking it. Okay, so Carey-Coombs murmur is an MDM murmur.
Yes, ma'am.
Okay. So there is no features of rheumatic carditis.
Yes, ma'am.
Then
and he is in NIHA class, New York Heart Association class 3, ma'am.
New York class association. Okay. So this is your final diagnosis.
Yes, ma'am.
Okay. You don't want to change it to rheumatic heart disease.
Ma'am, I would change it
You
now
would like
after
to
the
change it.
discussion.
Okay.
Ma'am, this is a chest X-ray which is showing cardiomegaly, and just a positive finding, ma'am. Cardiomegaly with
Based on this X-ray, can you see this pulmonary hypertension?
yes, ma'am. There is peripheral oligemia with a dilated pulmonary vasculature, central pulmonary
What
vasculature.
about the pulmonary bay? Is there any straightening of heart border, or the pulmonary bay is quite good?
Straightening is.
There is no straightening. No, the pulmonary bay is quite good.
Yes.
Based on that, you can't say there's pulmonary hypertension, but I do agree there is some peripheral oligemia in this patient. Okay. What chambers of this heart are enlarged?
There seems to be a left atrial enlargement because, ma'am, I thought the carina was a little splayed, but I could be wrong.
Okay. More than that, which atrium is enlarged?
The left, which atrium? ma'am?
Uh,
The right atrium is.
how do you say this is right atrial enlargement?
There's no double.
When there is occupying more than
left.
2 intercostal spaces, no? And also from the spine, what is the right heart border? Is it more than 2.5 centimeters?
Yes, ma'am, it is.
So then there is definitely right
Left
atrial
atrium.
enlargement.
Yes, ma'am.
Right atrial enlargement. Left atrium will be seen as a
Straightening.
shadow within a shadow. We can't see any shadow, no? So we can't see a left atrial enlargement.
Yes.
And what about the apex? It's LV apex, RV apex.
Seems like an LV, like
It's an LV apex. An RV apex, what happens?
it's lifted up.
It's lifted up. So it will look like a boot end. So it'll be lifted up. So this is a LV apex. So left ventricle is enlarged and the right atrium is enlarged. That's all we can find from this X-ray.
Ma'am, this is the ECG of the patient, and the ECG is showing features of left ventricular hypertrophy, and this seems more of a volume overload state than a pressure overload state.
No, this is not volume overload.
There is, I could not find ST depressions or T wave changes to suggest a pressure overload. There
This is
are
not
deep,
typical of a volume overload. There is LVH that we can
Yes.
agree on. Then what else is there? What's happening to the P wave in L2? Is it broad?
yes, ma'am.
It's more than two small squares,
It is,
no?
ma'am.
And it's also looking like an M. Does it look like an M? No. So it's a P mitral, no? So there is left
It,
atrial
atrial
enlargement.
Yes, ma'am.
And also, what about V1? The P wave is more negative. So again, it indicates a left atrial enlargement.
Yes, ma'am.
So there's LVH and LAE in this person.
Yes.
Any other investigations? What are the specific investigations would you like to do for this person?
Ma'am, I would get an echo done.
You would get an echo done. Okay. Then
Following that, if the diagnosis of aortic stenosis is confirmed,
how will you manage the patient? So
Yes,
you've got an echo done. There's a aortic stenosis and mitral regurgitation.
yes, ma'am.
I'm telling you, I want to give ACE inhibitors.
ACE inhibitors would the afterload is reduced, so that would
ACE inhibitors should be given in what lesions?
mitral.
Regurgitation lesions. So we can't give in somebody with stenosis. Again, it will cause vasodilatation and it
Yes,
will cause severe problems. So how will you manage this person?
I would if he was in he's not in failure currently, but if he was in failure, I would fluid restriction, salt restriction. Since he has an aortic stenosis, I would advise him to avoid exercise and strict bed rest.
Based on this thing, is a severe AS or not?
It is severe, ma'am, because he's
Severe AS.
Yes.
What is the current recommendation for severe AS? Whether symptomatic or asymptomatic, what is the management?
he will need a valve replacement.
You
ma'am.
have to do a valve replacement. So once you've diagnosed severe AS, it's valve replacement.
Yes, ma'am.
So now you then there is MR also, no? So what will you do?
It will be a double valve replacement.
So you have to do double valve replacement. What about TAVI?
Since it's a double valve replacement, I can't do a TAVI.
Yeah, you would prefer to do a
Surgical.
Once you have replaced the valve, now you have replaced the valve. You have replaced both the valves. So where will you? So you're examining the patient again. What are the findings you think you'll find in this person?
I would expect a prosthetic click.
Where will the aortic prosthetic click be and where will the mitral click be? Any idea?
Not sure.
It's easy. Aortic is systolic and mitral is diastolic. So if you hear prosthetic clicks in those areas, that means it is, if it's a systolic one, it's aortic. If it's diastolic, it is mitral. So you can examine the patient and find out where the lesion is. So what are the other causes of, so we discussed AS and MR.
Yes, ma'am.
Yeah. Can you, any other causes of acute MR?
Ma'am, an acute
Causes of acute MR?
Acute MR, ma'am, if it's an infective endocarditis, they could have an acute
One
MR.
infective endocarditis.
Acute myocardial infarction.
Acute myocardial infarction. Then
trauma or post-surgical.
so these are the most common causes of acute MR.
Yes, ma'am.
Okay. So acute AR?
Acute infective endocarditis
Same.
again is yes, ma'am.
So the same causes, except MI. It's infective endocarditis. What is the other thing? When they have accelerated hypertension and acute AR? Dissection. So you can have a dissection, or the third one is trauma. So those are the three causes of acute AR. Okay. So yeah, so you'll do valve replacement and you will maintain
I would anticoagulate him for that.
Okay, fine. Okay, that's all I have to discuss. Any questions from the audience or anything online? Okay, so validations are easy. So but you have to learn about sounds, where they are and present in order, and also know about what are the timelines of presentation. So we are now thinking congenital, no? So we can't go back and say this is I mean, you are thinking it's congenital. You can't say this is bicuspid. Bicuspid will present only above the age of 50.
Yes,
Remember that. Because of shear stress and calcification, you need that accelerated process to happen for them to develop a bicuspid aortic valve with AS.
Yes, ma'am.
Okay. And also, when you say it doesn't radiate to the carotids, there is an issue there. What are the conditions in which AS will not radiate to the carotids? AS murmur will not radiate to the carotids. When we have something called an atherosclerotic or AV sclerosis, in that case, it is only a function. It is not causing a severe AS.
Yes.
Only the murmur is there. And second, when you have an AS-AR and it's a functional AS. So that is my worry, that you're saying it's not radiating to the carotid. Then we are worried whether it's organic or not. But what tells you it's organic? It's only the murmur with a thrill. So that is why we are considering all. So when you are confused like this, what else can you do to look for the thrill? What could you have done on your auscultation?
To look for the thrill, carotid thrill, ma'am.
You could have looked for the carotid bruit. Instead, you should have just looked for the bruit. Like even if you couldn't feel the thrill, just look for the carotid bruits to see whether it's still radiating. Okay. So whenever you're presenting, you should look for internal consistency. That is what I'm trying to tell. So it has to be consistent with your previous presentation. Like each thing has to be consistent. Okay. So any other questions from online? Dr. Anita, are you there? Okay. In that case, can we close this session? Thank you, Dr. John Roy, for the good presentation, and you have worked up the patient very well. And you were able to field a lot of answers, so that's good. All the best for your exams.
Thank you, ma'am.
Thanks for everyone for joining us. Thank you.